Hello, my name is Alex. Welcome to my channel. This is the first video of our Human Growth Anatomy series. Today I'm going to talk about the central nervous system and the peripheral nervous system. Before we start, I would like to let you know that there are two methods to study human growth anatomy. You can study by either systematic approach or regional approach. The systematic approach has the advantage of providing the big picture of each system and is a better way to understand the function of that specific system. On the other hand, the regional anatomy is the study of the relationship between parts of the different systems in a certain region. So for today's content, as it is indicated in the title, we are going to proceed with the systematic approach. First thing first, let's take a quick review on the terminology. If you're not interested in this section or have learned it somewhere else, you're welcome to skip it. This is a person standing vertically with both palms facing forward. By definition, this person is in the anatomical position. We have 6 terms to indicate the locations of anatomical structures in this position. The first one is superior, which means high or above. For example, the head is superior to any other parts of the body. The opposite of superior is inferior. So for instance, the feet are inferior to the knees. A pair of terms are kind of interesting. You might be thinking about left and right at this point. Yes, apparently we do use such kind of vocabulary in anatomy, but more often, in case of two structures being on the same side, we use lateral and medial to indicate their relative locations. Lateral means on the side and therefore not in the middle. On the other hand, of course, medial means in the middle. For example, the thumbs are lateral to the little fingers, or in a different perspective, the little fingers are lateral to the thumbs. The last pair of terms I'm going to explain are anterior and posterior. Anterior means in front of something. It refers to the direction where the person is facing towards while remaining in the anatomical position. The opposite of anterior is posterior, which means behind something. Sometimes anterior and posterior are replaced by the terms ventral and dorsal respectively. Ventral refers to the abdominal aspect or the belly side. Dorsal refers to the back side. Therefore, anterior is equivalent to ventral and posterior is equivalent to dorsal. These 3 pairs of terms can describe any relative locations of different structures in the 3-dimensional space when the person remains in the anatomical position. Once we construct a coordinate system, these terms fall on the opposite termini of x, y, and z axis. The 3 axes intersect with each other and form the median point, the coronal point, and the horizontal point. As you can see in this picture, the median point divides the body into left and right parts. The coronal point divides the body into anterior and posterior parts. The horizontal point divides the body into superior and inferior parts. Okay, that's all for our terminology review. Now let's dive into today's new content. Before we talk about central and peripheral nervous systems, we need to know what the nerves are. This is a single nerve cell, aka neuron. As you can see, the bulky part on the left is a cell body. The structures like little tree branches are called dendrites, and the long string-like structure is the axon or nerve fiber. A nerve is essentially a bundle of axons. There's an important concept called ganglion, which is defined as a collection of neuronal cell bodies. Since the cell bodies are much larger than their axons, the ganglia usually look like large nodes on the nerves. For example, the ganglia on spinal nerve roots are made of cell bodies of sensory neurons, which are so readily visible that we can use them as landmarks. We'll see this later in greater details. For another example, inside the ganglia on the autonomic motor nerves, the preganglionic axons synapse or make contacts with the postganglionic neurons. Pre means before and post means after. A preganglionic axon is the one that departs from the central nervous system and reaches out to the ganglion. Thus, it is proximal or closer to the central nervous system. On the other hand, the postganglionic nerve is the one whose axons depart from the ganglion and reaches out to smooth and cardiac muscles, which is distal to or further away from the central nervous system. Please keep this picture in your mind. We'll see these concepts later. The central nervous system consists of the brain and the spinal cord. They are contained in the skull and the vertebral column, and they communicate with the rest of the body through 12 pairs of cranial nerves and 31 pairs of spinal nerves, respectively. The peripheral nervous system includes pretty much all the nerves outside the central nervous system. All these nerves are distributed throughout the entire body, and they are either directly or indirectly connected to the central nervous system. Of course, the nervous system can be subdivided into central and peripheral nervous systems based on physical separation, yet it also can be subdivided into somatic and autonomic nervous systems based on functions. The term somatic refers to voluntary control and autonomic refers to involuntary control. The somatic motor nerves provide motor information from the central nervous system to the skeletal muscles for voluntary control of movement and posture. The somatic sensory nerves provide conscious sensation to the central nervous system from skin, mucosal surfaces, and organs. The autonomic nervous system is responsible for reflex control of smooth muscles, cardiac muscles, and secretory glands. This is a picture of the head cut in half. You can tell we are looking into the skull from the median plane. The brain is contained within the skull. There are 12 pairs of cranial nerves emerging from the brain, and they innervate muscles, skins, and glands in the head and neck. We'll see them in the future with greater details when we explore the regional anatomy of head and neck. The spinal cord is connected to the brain through the brainstem. In fact, the spinal cord begins its continuation of the brainstem, exits the skull through the foramen magnum, and extends to the level of intervertebral disc between lumbar vertebrae L1 and L2. So this is what a foramen magnum looks like. Foramen means hole or perforation. Magnum means the largest one. So this is the biggest hole in the entire skull. It is so big because it must let the spinal cord through. This is a vertebra. It has a body and an arch. Many vertebrae articulate with each other at their superior and inferior articular surfaces so that they form the vertebral column. The vertebral foramen in each vertebra collectively forms a vertebral canal, which contains the spinal cord. There's a notch between the arch and the body. It's called the intervertebral notch, and it's where the spinal nerves exit the vertebral canal. Okay, speaking of the spinal nerves, let's take a close look at its organization. This is the view of a spinal cord cut by a horizontal plane. The structure with a sort of H shape in the middle is the gray matter, and the surrounding substance is the white matter. The anterior or ventral gray horns are relatively thin, and the posterior or dorsal gray horns are thicker. Once you know these landmarks, you will be able to orient yourself and identify other structures in immediate proximity without any given hints. This is important if you are going to study anatomy as a major, but it won't matter so much if you're just watching this video for fun. Anyway, this is a horizontal section of the spinal cord. Now let's add spinal nerves to it. The motor rootlets emerge from the ventrolateral aspect of the spinal cord as the sensory rootlets come out of the dorsolateral aspect. The motor rootlets converge to form the ventral or anterior roots, and the sensory rootlets converge to form the dorsal or posterior roots. Eventually, the roots come together and form the spinal nerve that exits the vertebral canal through intervertebral notch. Note that the posterior root makes a ganglion right before it merges with the anterior root. Sensory information is sent to this ganglion and then the central nervous system. There are 31 pairs of spinal nerves, including 8 pairs of cervical nerves, 12 pairs of thoracic nerves, 5 pairs of lumbar nerves, 5 pairs of sacral nerves, and 1 pair of coccygeal nerves. They are distributed along the spinal cord, dividing it into 31 segments. A given spinal cord segment and its corresponding spinal nerve will consistently innervate a particular region of skin called a dermatome. A dermatomal map of the body describes the location of each dermatome. Such information is used during sensory testing to localize sensory loss to specific spinal cord segments. For example, if a patient has completely lost his sensation in his ring and little finger, then there might be something wrong with his spinal nerve C8. Please keep this concept in your mind. We'll see it more often when we talk about some clinical cases later. Most of the dermatomes look like a ring-shaped strap around the body. It makes sense because their segmented distribution just follows the order of spinal cord segments. Yet some of them are long straps almost vertically distributed along the limbs, which is counterintuitive. But if the person bends over, everything makes sense then. If you compare this to some random mammal's dermatomal map, you will find that they are surprisingly similar. This might be another piece of evidence for evolution. Okay, back to anatomy. The central nervous system, in other words, the brain and the spinal cord, are covered by a three-layer structure called meninges. Spinal meninges are supportive layers of fibrous and elastic connective tissue that surround the spinal cord and are continuous with the cranial meninges that encircle the brain. The outermost layer is called dura mater. Dura means hard or durable. Mater means mother. So dura mater plays a protective role. The space between bones and dura mater is the epidural space, which is the site of epidural anesthesia and epidural hematoma. It extends to the S2 level of the vertebral column, where it ends as a blind sac except for a thin tubular extension, which is a coccygeal ligament attached to the coccyx. The middle layer is called arachnoid mater. Arachnoid means like a spider. The arachnoid mater is a layer that looks like a spider web. It also extends below to S2 level, lines the dura, and ends as a blind sac. There's a potential space between arachnoid mater and dura mater called subdural space. The innermost layer is called pia mater. Pia means soft. It tightly invests the spinal cord. At L2 level, it continues as a thin extension, the filum terminale, which perforates the arachnoid mater and dura mater at S2 level and continues within the coccygeal ligament. The space between pia mater and arachnoid mater is called subarachnoid space. It is filled up with cerebrospinal fluid, or CSF. You might have noticed in this image that the spinal cord is not as extensive as the dura mater and the arachnoid mater. In fact, this is determined by the fetal development. Early in fetal life, the spinal cord and the vertebral column are coextensive, and the spinal nerves arise opposite their corresponding intervertebral foramina. However, during development, the vertebral column grows more extensively than the spinal cord, such that the roots of the lower spinal nerves must travel downward within the vertebral canal to reach their appropriate intervertebral foramina. These descending roots look like the tail of a horse and thus are called the caudal equina. The arachnoid mater and the subarachnoid space continue down to the S2 level, so the nerve roots of the caudal equina are bathed in CSF. Speaking of the CSF, it's inevitable to talk about a lumbar puncture. It's a procedure for CSF collection. Once the specimen is collected and sent to the lab, they can run a test and see if there's infection. Usually the doctor would insert a needle between vertebrae L3 and L4 or between L4 and L5. The needle will enter the subarachnoid space and push the caudal equina to the side, but will not damage the spinal cord because the puncture site is well below the spinal cord. Thus, the entire procedure is quite safe even though it might look scary. The only concern here is the puncture site sanitization. Okay, that's pretty much all about the general physical structure of the central and peripheral nervous systems. Now I want to briefly touch on the autonomic nervous system. The autonomic nervous system is largely involved in involuntary control, which is opposed to the somatic nervous system. It regulates functions of internal organs by innervating smooth muscles, cardiac muscles, and secretory glands. As it was presented in the beginning of this video, the autonomic nerves are organized as chains of preganglionic and postganglionic neurons. The autonomic nervous system can be subdivided into sympathetic nervous system, the SNS, and parasympathetic nervous system, PSNS. SNS and PSNS play opposite roles and are both regulated by hypothalamus. The SNS prepares the body for fight or flight response, and the PSNS makes the body calm down. The balance between them ensures the smooth functioning of internal organs. The SNS exclusively comes out of T1 through L2 spinal cord segments, so they are called thoracolumbar outflow. The preganglionic nerves in SNS come together to form a sympathetic trunk, where they travel to the appropriate level to synapse with the postganglionic nerve. Then the postganglionic nerve leaves the sympathetic trunk to join any of the 31 pairs of spinal nerves. On the other hand, the PSNS nerves emerge from the brainstem and the sacral segments of the spinal cord. Thus, it is called the craniosacral outflow. In other words, the regions of SNS and PSNS nerves do not overlap. These parasympathetic nerves travel in cranial nerves 3, 7, 9, 10, and spinal nerves S2 through S4. The parasympathetic nerves traveling in the cranial nerves reach out to the parasympathetic ganglia in the head, neck, and abdomen, and the ones traveling in spinal nerves reach out to the parasympathetic ganglia in the pelvis. Finally, let's talk about some clinical conditions related to central and peripheral nervous systems. The first one I'm going to talk about is acute anterior poliomyelitis, aka polio. It is a disease caused by a virus that enters the body through mouth. The virus multiplies in the intestine and migrates to the central nervous system. It destroys the motor nerves emerging the anterior gray horns. Infection can cause total paralysis within a few hours. Patients will also suffer from atrophy of the denervated muscles. This is an example of pure motor lesion. Fortunately, this disease has been eradicated in most countries and will be eradicated globally very soon. Herpes zoster, aka shingles, is a viral disease. The same virus causes chickenpox. After an episode of chickenpox, the virus lays dormant in the dorsal root ganglia. Therefore, the shingles is basically the adult version of chickenpox. But the regions affected by shingles follow the dermatomal map more rigorously. Symptoms include painful rash and sensory loss. This is an example of pure sensory lesion because the virus only travels in the sensory nerve fibers. The best way to avoid shingles is to avoid chickenpox during childhood and receive 2 doses of chickenpox vaccine. The intervertebral disc can bulge posterolaterally and compress the spinal nerve in or near the intervertebral foramen, resulting in pain and or weakness in the distribution of the affected spinal nerve. This is an example of mixed motor and sensory lesion. Chronically high blood sugar can permanently damage small blood vessels, leading to reduced blood and oxygen supply. As a result, some nerves, especially the ones in the distal parts of the limbs, will die. This process is called diabetic neuropathy, which is one of the most common diabetic complications. This is also an example of a mix of motor and sensory lesion. If the patient's blood sugar continues to rise and reaches the point where the major arteries get damaged, necrosis will take place, usually in the lower limbs. At this point, the necrosed limbs must be amputated to save the patient's life. So, diabetic people, for your own safety and life quality, please make sure you watch out for your blood sugar. The more you know, the less you fear. I hope you find this video helpful and have learned something about central and peripheral nervous systems. Please take care of yourself and your family. Thank you for watching. See you next time.